So I think I will begin because I have a few opening remarks that I want to make before turning to Sally, and indeed to Dr. Alimi from the Africa CDC. So if I may, I'll kick off. And just to say, a very warm welcome, good morning. Thank you for coming to this celebration of the final sharing and learning event of the Commonwealth Partnerships for Antimicrobial Stewardship Programme, known as CwPAMS. My name is Ben Sims and I'm the Chief Exec of THET. We're expecting actually over 100 people and have a number of very distinguished speakers. It's going to be a really, really fantastic morning. I say morning because that's what it is here in London. We're using the hashtag CwPAMS. So Twitterati, get your fingers moving, please. It has been the great privilege of THET to work in close partnership on this programme with the Commonwealth Pharmacists Association and with the support of the Fleming Fund team at the Department of Health and Social Care in England. The programme has been championed throughout by two outstanding individuals, Dame Sally Davies, who I'm delighted to be welcoming to give our opening keynote speech, and Dr. Keith Ridge, the Chief Pharmaceutical Officer at the NHS England, who will be speaking tomorrow. At the heart of the programme, however, has been the 300 volunteers from across the UK health community and our partners in low middle income countries. It is their energy and their brilliance that the programme has tapped into and that we will be celebrating and focusing on today. If I may, can I ask people when they're not speaking to go on mute? I'm conscious I've got that kind of washing up sound experience that we sometimes get. Thank you, Anja. And what a success it has been. Over the past 2 years or so, over 3,000 health workers have been trained across 4 countries of Uganda, Ghana, Zambia, and Tanzania. 23 guidelines and protocols have been rolled out across low middle income country health institutions. 20 revised documents developed for antimicrobial stewardship and antibiotic prescribing. You'll hear a great deal of reference today to the health partnership approach, which is at the heart of the programme and of THET's work more generally. The definition we use of health partnerships is important to us, and it's as follows. Health partnerships are a model for improving health and health services based on ideas of co-development between institutions from different countries. The partnerships are long-term and based on ideas of reciprocal learning and mutual benefit. There are a number of important concepts there, not least the idea of co-development and of bidirectional learning. At this meeting, we acknowledge and celebrate the benefit the UK derives from engaging in this work, and 16 UK institutions have benefited from engaging in this. The power of partnerships throughout the independent evaluation conducted by Ingentium is celebrated. It points to another truth about partnerships, which is the positive intended and unintended consequences of bringing talented people and well-motivated people together. I celebrate in particular the ways in which this programme has raised the status and visibility of pharmacists in hospital settings and in global health activity. Today, you will have an opportunity to hear about the direct and indirect outcomes, and especially during the breakout sessions, when you will get the opportunity to dive into the particular countries. I cannot open this meeting without acknowledging how brilliantly the people involved in this programme have responded to COVID-19. And I say this conscious that today the pandemic is out of control across the African continent. We are hopelessly short of achieving equity in the distribution of vaccine. Those of you who are attending this conference from Africa, we salute you and we are thinking of you at this time of enormous peril. It was long ago as March the 2nd, 2020, when overseas travel for NHS staff came to an end. And by the 23rd of March, the UK was in lockdown. You might have reasonably expected that all CwPAMS work would have ended then. It didn't. And one of the most impressive pieces of evidence of the power of partnerships for me is how people involved in CwPAMS have both maintained their work on antimicrobial stewardship throughout this time, but also pivoted to help people solve and facilitate responses to COVID in pragmatic and innovative ways. The 12 partnerships were praised by external evaluators for their ability to do this. I'm thinking, for example, of the Brighton Lusaka pharmacy link, which set up an alcohol-based hand rub facility run by trained pharmacists and increased production by 400% during COVID. The people we will meet today have proven their ability to respond with urgency and purpose to the COVID-19 pandemic. But the focus of our efforts, of course, is the silent pandemic, which is in so many ways more frightening still. The threat to medicine as we know it, the growing resistance to antimicrobials born of the overuse and misuse of antibiotics. And one of the questions I know everyone will be asking themselves during this meeting is, how do we ensure the world prioritizes this silent pandemic in a way that we so obviously fail to do in anticipating coronavirus? There is no better person to speak on this theme than Dame Sally Davies. Sally, we are honoured to have you with us. Sally is, of course, the UK's Special Envoy on antimicrobial resistance. She is also a long-standing champion of the value of engaging globally, both in her own clinical career and in her official roles. Your 2019 report as Chief Medical Officer was a crucial landmark in articulating the value of a globally engaged NHS and of the importance of antimicrobial stewardship. At THET, we also still remember your wonderful closing keynote remarks at our 2017 conference, in which you spoke of the need for global health and global health security to go hand in hand to ensure that everyone, everywhere is safe and healthy. Never have those words been more true than they are today. Sally, thank you for joining us, and over to you.
Thank you so much, Ben. You are inspiring and a wonderful steward for the THET programs, which, as you know, I think are fantastic. It's a very important meeting, and for me, it's important to join you at this Commonwealth Partnerships for Antimicrobial Stewardship Sharing and Learning event. We were talking earlier on about how it matters bringing everyone together. And here we're celebrating and showcasing all the great work that CwPAMS has been doing in what we are calling the slow pandemic, antimicrobial resistance. And actually, I can tell you from the G7 health ministers and other G7 meetings that the term slow and silent pandemic is actually beginning to get some traction. Your commitment to collaboration and working together is inspiring. You are actually all totally inspiring. And it is work that you do and people like you from the bottom upwards about basic training, developing, that will turn the tide in this AMR pandemic. As key stakeholders of CwPAMS, you'll be aware that the resistance of bacteria to antibiotics is a growing threat to modern medicine and our ability to treat infections. We've started thinking about antibiotics and anti-infectives actually as infrastructure. I cannot imagine an effective health system without a good wash, clean water and sanitation, and effective antimicrobials. Though, of course, in Africa, I have seen places which look after patients with great care without both of those. So we have to go on working. The illnesses that we've made Global progress on treating, such as TB and malaria, could become untreatable if we don't take this forward. And drug-resistant infections, like any other infection, don't respect national boundaries, as we know, and kill people indiscriminately worldwide. The current figures put this at more than 700,000 people each and every year actually dying directly of untreatable infections. And the global AMR-related deaths are predicted to rise to a good 10 million every year by 2050, with 89% of those AMR deaths occurring in Africa and Asia. That's not equity. That's not fair. We've got to take action. Low and middle income countries are going to be disproportionately affected given the higher prevalence of infectious disease, and they're going to experience even greater drops in economic growth, threatening development gains if we can't stop this in its tracks. If the current trends in the increase of AMR continue, common infections are going to become more complex and expensive to treat, with consequences for the health systems and an increase in poverty linked to household healthcare costs. The World Bank estimated that an additional more than 28 million people would be pushed into extreme poverty if we do not take action. So it doesn't matter where we are in the world. A patient could find themselves with antimicrobial resistance, and that causes longer hospital stays, more complex and costly treatment. Actually, in the UK, AMR directly costs the NHS an estimated £95 million a year. Think what we could do with that money if it wasn't being used for AMR. Whilst a study in South Africa demonstrated that drug-resistant TB treatments cost 80 times more than if the drugs work. That's not sustainable. And again, I highlight to you that it's unacceptable because it's not equitable. No, so you've got AMR, so you have to pay even more. That's not fair. The resulting burden on health systems and services for care and prevention threaten our achievement of universal health coverage. You in Africa understand that far better than I do. You live with it. But as a result, AMR is putting the delivery of the SDGs related to health, agriculture, animals, the environment and food directly at risk. The world can't achieve the SDG target on universal healthcare without addressing AMR, and we won't be able to get a grip on AMR until we build equitable, resilient and sustainable healthcare systems. They're kind of in tandem. They're so inextricably linked. And as I said, as they're essential healthcare infrastructure, they're valuable as antibiotics and antimicrobials when they're used. But actually, we argue they have a value on the shelf ready to be deployed. So ideally, we're aiming for a Goldilocks scenario for antibiotics and their use, not too little and not too much. That's why efforts to tackle AMR, such as ensuring access to quality and effective antimicrobials at the appropriate dose and research into new products, are essential to achieving universal health coverage. We need to protect and preserve antibiotics for as long as possible to save the lives of millions, not only for now, but for future generations. The trajectories on AMR were increasing even before the current COVID-19 pandemic, which is set to increase the prevalence of AMR. First, it can result, COVID can, in secondary bacterial infections such as pneumonia, which do need antibiotics. But secondly, antibiotics are being prescribed to patients just in case, in order to prevent infection, particularly if they are on mechanical ventilators. This increased use of antibiotics can lead to drug resistance. We all know that, and we're seeing evidence of this. The rate of bacterial co-infection in COVID-19 patients on admission to hospital in one very big study was only 3.5%, and the rate of secondary bacterial infections 14.3%. But it was estimated that up to 75% of the COVID patients received antibiotics. Thirdly, there's an increased risk of healthcare-associated infections to COVID-19 patients who have increased hospital and very long hospital stays. So COVID is not good for AMR, as well as being such a sad disaster for all countries. I've been calling COVID-19 a lobster. It's been dropped into the boiling water and it's making a blooming awful racket and suffering. Whereas AMR's, the lobster put gently into cold water, heating up slowly. So in the long term, it is going to die. But according to the RSPCA, it doesn't suffer. And I can tell you, it doesn't make any noise. Well, that means when it's under our nose, we may not even see it because there's no noise. And I think AMR's that slow pandemic, the lobster slowly heating up. And we've got to get that lobster out of the pan before it's too late. We can't afford to let one pandemic accelerate another. And that's where the Fleming Fund comes in. As you know, the Fleming Fund is a 265 million UK aid programme with data at its heart, supporting up to 24 low and middle income countries generate, share and use data on AMR. It's managed by our UK Department of Health and Social Care, and it's the world's single largest ODA investment in global AMR surveillance. I know it's very important to the countries who receive it. And it's this Fleming Fund that's funded CwPAMS to improve antimicrobial stewardship practices, infection prevention control measures, and build antimicrobial expertise in this fight against AMR. I'm absolutely thrilled to see the progress CwPAMS has made since 2019. In other words, all of you to leverage the expertise of UK health institutions, volunteers and technical experts, but actually not only strengthening the capacity in Africa, but our African colleagues in partnership, as I learned when I went many years ago on a THET exchange, teaching our people things that they needed to learn, learning together with the workforce and institutions in Ghana, Tanzania, Uganda, and Zambia. By investing in AMR now, we believe we reduce the impact of the AMR pandemic in the future. Antimicrobial stewardship, infection prevention and control are always going to be the cornerstones for tackling infections, AMR, and we know that during the pandemic, they've been critical to contain the spread of both COVID-19 and hospital-acquired infections. CwPAMS have been key players in this space, focusing on upskilling healthcare workers to help their communities stay safe from infections. The antimicrobial stewardship guidelines and strategies developed by CwPAMS have enhanced healthcare workers' response to COVID-19. They've tasked the medicines and therapeutic committees with formulated COVID-19 specific protocols and procedures, as well as procedures for isolating suspected and confirmed cases and the necessary IPC processes that should be utilised. This is strengthening health systems at its best. And one of the partnerships with the University Teaching Hospital in Lusaka, Zambia, have produced an AMS training module and handbook of standard operating procedures for hand sanitizer making. Gosh, these training and practice tools are going to enhance healthcare workers' response to COVID-19 in Zambia and broader. And these changes, importantly, are sustainable and tailored to your local communities who will go on driving action. Right now, across the world, from labs to hospitals, science is coming to the rescue of society in its response to COVID-19. So I hope we're not only learning from the current pandemic, but also from each other. As countries, communities, and even campaigners, and I think I've shifted into that group, we have to share insight and ideas with each other so we can all do better. We know it's not too late to prepare for COVID-19, but we can and we must prepare for the current and future threats our world faces. And remember, the WHO have said that lack of innovation for new and accessible treatments means the world is failing on AMR. Just 2 weeks ago, I laid this out rather loud and clear to the health ministers of the G7. I challenged them face to face to work together and to work with industry and their finance ministerial colleagues to balance innovation, access and stewardship. I urge them to build on the advances made in R&D for COVID-19 by acting strongly and across disciplines. So I'm really pleased today to tell you G7 are committed to bold steps and that they're going to waste no time getting going. After all, we still have the presidency until the new year. The G7 leaders agreed to act now to tackle AMR, and we're going to do this through exploring concrete incentives, options to bring new antimicrobials to patients. That's a huge step, and it's crucially got to secure global access. By developing a shared set of valuation principles, G7 will value antibiotics as essential infrastructure that they really are. We know if countries around the world implemented innovative approaches to paying for antibiotics, then collectively this would give healthcare systems around the world the best chances of treating us. So that's what we're going to do. This year's G7 has collaboration at its heart. Our health ministries have also agreed to work with industry to strengthen supply chain resilience through a broader, more geographically diverse, quality-assured manufacturing base. And I'm delighted they're going to work to build knowledge about AMR and the environment and move to agree international standards on the safe concentrations of antimicrobials released into the environment from pharmaceutical manufacturing or healthcare facilities. That's new, but if we work together, we can make it happen. We can protect our publics, our communities. Also, at the Commonwealth Health Ministers meeting that took place in May, we were able to include an important AMR reference in the final ministerial statement that called for continued investment to strengthen integrated health systems and support national action plans on AMR to guard against future pandemics. I'm so proud that we now have 135 countries finalised with their national action plans in alignment with the WHO's Global Action Plan. Much of the stewardship we're seeing has been voluntary, and in every country now, we need to formalise and fund the commitment, starting off by ensuring the national action plans are prioritised politically and financially. You, from CwPAMS, have made significant inroads here. The health partnerships have contributed to national action plans for improving awareness and understanding of AMR, strengthening knowledge and evidence base through improved surveillance, improving the IPC policies and SOPs, and optimising the use of antimicrobial drugs. This is essential. Well done. It wouldn't have been possible without all of you, and I congratulate you and thank you for playing your part and actually showing others what they can do too. You are leading the way. I'm delighted that our UK Department of Health, through our Fleming Fund, has confirmed further funding for CwPAMS, not sure whether you know about this, to enable it to continue its vital work well into 2022. And I shall be fighting hard in our next spending review for yet more money for the Fleming Fund. So, as I finish, I want to give a huge thank you to you, Ministry of Health officials, members of the AMR coordinating committees, national pharmacy associations in Ghana, Tanzania, Uganda, Zambia, for facilitating partnership work and attending today's event. Your active engagement in recognising the achievement of partnerships, developing and endorsing guidelines and protocols, and in some cases, actually rolling them out nationally, amazingly difficult, I know, has empowered the health partnerships to make a really long-lasting impact. Thank you. You've also helped, actually, and importantly, to elevate the status of pharmacists who play a vital role in antimicrobial stewardship. So I urge you not to stop here. We need your continued engagement, recognition and endorsement to sustain what's been achieved and to successfully combat AMR. AMR's not going away. I want to give a personal and programme thanks to Dr. Keith Ridge for his great support and engagement from the conception of the programme to now. I hope he's going to stay involved as he moves out of his present job in some months' time. And also to the healthcare workers and volunteers who devoted their time and energy to the programme within the UK, Gambia, Tanzania, Uganda and Zambia. I'm told the volunteers have given over 4,000 days of time to CwPAMS, When the pandemic hit, despite not being able to travel, you maintained knowledge exchange, worked hard to continue to deliver and play a vital part in your countries. Well done. And you've made a difference to COVID-19 too. It's your efforts that brought about improved antimicrobial stewardship practices within your health institutions. And of course, a huge thanks to inspirational THET and CPA, who've done amazing jobs managing the grant, providing technical expertise. The success of the project is a testament to you all. And I want to end by recognizing and celebrating how much CwPAMS has achieved. I'm a firm believer, as many of you recognize, that the more we know, the more we can act. So today we're going to hear about the great tools and resources that you've been developing. We'll share ideas today and tomorrow on how to sustain the progress made. We'll discuss lessons learned and how to embed them into future AMS partnerships and health partnership approaches. And in the middle of all this, remember, if we're going to have a chance to beat AMR, we've got to work together, go on collaborating and aligning activities to support our counterparts in Commonwealth Ministries of Health to achieve their national action plans. I look forward to working with all of you to make this happen. Thank you.
We were reflecting earlier on the good things about Zoom, which is lots of people can come, and we've been joined by people from Malaysia. The bad thing about Zoom is we can't applaud you. May I say, therefore, on behalf of us all, Sally, thank you so much. That was so inspiring. You are always inspiring. You're an outstanding scientist, and you are indeed that outstanding campaigner. We are so proud to work with you, and thank you very much for that opening keynote speech. I will move on, but if people have questions, do by all means begin to put them in the chat box. But Sally, thank you so much. I also note the rather good news of your funding announcement, which is excellent. I think today we'll be very, very much focused on understanding the value we've contributed so far, and that is our challenge. You know, this funding is precious, and this opportunity is precious, and so that is very much our focus for today. But I think more details about the future scheme will be shared tomorrow. But thank you again, Sally, for joining us and for that inspiring talk.
Thank you.
I'm now going to introduce, if I may, Dr. Alimi, who is from the Africa Centers for Disease Control and Prevention. Dr. Alimi, it's wonderful that you can join us to give your very important perspective. I'm terribly impressed by both the breadth of your expertise, which straddles veterinary medicine, public health policy, and research. And we heard Sally talk about the importance of agriculture as well as human use of antimicrobials, but also by the breadth of your the locations in which you've worked, Austria and the UK as well as Nigeria. So it's with a very warm welcome that I turn to you, Dr. Alimi.
Thank you very much for that. And it's spelled Alimi, so the alpha there should be replaced with an indigo. Thank you very much for having me. I'm delighted to be here, and I could not say no to this invitation because of how much that how remarkable the work that CwPAMS has done, and particularly because it's been country-driven. We're really delighted to see many of our member states on this call as well, and thank you very much for having us at Africa CDC. Good morning to you all, colleagues, and afternoon if you're joining in from some parts of Africa. We are delighted to be a part of this event. Thank you very much, Diane and team, for making sure that we have been involved in many of the works that you have been doing on the continent. Thank you very much, Dame Sally. That was a fantastic opening. I just had a chat saying that it's kind of hard to catch up with how passionate and how how informative your speech has been. But I've been asked to talk a bit about what we are doing on the continent, particularly as Africa CDC, and of course the African Union, on tackling antimicrobial stewardship. Antimicrobials remain an essential tool in the treatment, prevention, and control of human and animal infections. But what we can all agree is that AMR is a critical threat at a global level, but most importantly to Africa's health, security, and economic growth. It is estimated that millions of Africans will die from AMR by 2050 if important steps are not taken. Already on the continent, AMR has been documented as to be a problem for HIV and pathogens that cause malaria, TB, typhoid, cholera, and several other infectious diseases. Many of you may know us as Africa CDC from our remarkable continent-driven COVID-19 response. I'm pleased to share with you that the same commitment and the same country-driven and continent-driven approach applies to how we work on the silent pandemic AMR. To give you a backstory, in 2017, Africa CDC launched a framework for antimicrobial resistance control, which initially focused on mainly human health. However, understanding the need to fully embrace a multi-sectorial One Health approach and to take antimicrobial to the highest level of governance at the continent level, which is the African Union, we have evolved to ensure that our framework reflects on a multi-sectorial approach, and have recently launched our African Union framework for AMR control. This framework ideally describes several strategies and tactics for the African Union to improve surveillance of AMR organisms among humans, plants, and animals, delay emergence of AMR, limits transmission of AMR, and mitigate among patients already infected with AMR organisms. For today's talk, I will not delve into some of the other amazing work that we are doing around antimicrobial resistance control, but I will zoom in and try to make you understand or share some of the activities that we have been doing around tackling antimicrobial stewardship. As early back as 2018, one of the things that member states identified to us during a consultative exercise was the broad agreement that one of the components for improving antimicrobial stewardship in human health is having guidelines on when to use antimicrobials, what antimicrobials to use, and when they are indicated. It was also agreed that several of the guidelines existing on the continent are not based on locally relevant data. And most of them, AMR data, as many of you will agree, and guidelines are lacking in many African countries. Too often, our African clinicians have had to turn to guidance written from far away from the continent, not cognizant of their context or their needs. Many of the guidance do not really reflect the epidemiology or the susceptibility of infectious diseases in our own communities. In response to this gap, Africa CDC with several other technical partners, particularly the Center of Disease Dynamics, Economic and Policy, what we have gone on to do is develop an African antibiotic treatment guidelines for common bacterial infections and syndromes. Ideally, these guidelines could increase the proportions of physicians and other human health providers adhering to antimicrobial use guidelines. The purpose of this is to ensure that as far up to the north, down to the south, going to the east and the west of Africa, that we have our healthcare workers having access to expert recommendations for antibiotic selection, dosage, and duration of treatment for common bacterial infections and syndromes. Going beyond the adult population, at a granular level, having guidelines that can guide neonatal and pediatric patient populations on the continent. These guidelines will promote the appropriate use of antibiotics to prevent transmission and reduce the prevalence of antibiotic-resistant pathogens. This work really represents the first attempt by the African continent to take ownership of what appropriate antimicrobial use means for Africans. Not forgetting that beyond guidelines, there's a need to have the highest level of governance and the need to have political backing. We at Africa CDC are leading the high-level advocacy to the African Union heads of states and government. Last year, this group announced a strong political commitment to controlling antimicrobial resistance in Africa. The first of its kind on our continent, the African Common Position on AMR was officially adopted at the 33rd African Union Summit in February 2020. The African Union Commission has then further taken steps to make commitments to advocate that member states and regional economic communities adopt policies to enable long-term prevention and control of AMR. Beyond the political level, at a more technical level, you might be aware that in November 2020, the regional directors of the African Union, as well as regional tripartite organizations and UNEP, made an affirmative commitment through their regional communique to see how we can work and join forces together to address AMR on the continent. One of the things that we are really keen about is the advocacy. And many of you must have seen it through our joint initiatives and joint communication materials that have gone on out there to support antimicrobial stewardship. Our future work with member states and parity activities will continue to address issues on domestic financing. At the continental level, you might be aware that we have poor access and regulatory structures. We still need to consider things around substandard and fake antimicrobials. There's still gaps around inadequate microbiology infrastructure, and of course, poor AMR surveillance systems. At our level, we will continue to advocate that governments improve stewardship by funding trainings, ensuring that we have expert personnel, and invest in technology needed to implement and advocate for evidence-based stewardship programs. Most importantly, one of the things that we are really keen about is ensuring that all interventions are really tailored to the needs of our member states and to the needs of healthcare facilities. African governments must wake up and understand that addressing antimicrobial resistance requires a whole system strengthening approach. We need to implement policies to curb over-the-counter sales of antibiotics, but most importantly, we need to ensure that we maintain equitable access to antimicrobials when needed. Through our African medicines agencies, we are strongly working to ensure that we address gaps around substandard and falsified antimicrobials, which are widely available on the continent. Africa CDC is excited to be a part of this event. We remain committed to exploring collaborations and leveraging on existing health partnerships that already support African Union member states. We are delighted to have CwPAMS working so hard to improve antimicrobial stewardship on our member states. We are even more proud that many of these initiatives are really continent-driven, because that is the dream. That is what we want to see. We want to see our continent take a charge in its own story, in telling its own story, in driving its own interventions. We're really delighted to see several of our member states who have gone on to do remarkable work in collaboration with this initiative. The dream is to have many more of our member states. As you may know, African Union has 55 countries, 55 member states. We want to see many more of our member states benefit from these lessons shared today. We hope that we will be able to explore collaborations whereby some of these best practices can be shared at a wider reach, at a more continental reach through a continental meeting. So I'm hoping to take these conversations offline, and we can see how to explore this, where we can document these best practices and ensure many more of our member states can benefit from this. Most importantly, to the representatives of our member states here, Africa CDC remains incredibly proud of the amazing work that you have done. I say big congratulations to you, and we are incredibly proud of the work that you will continue doing. Finally, we can all agree, be it member states, technical partners, or civil society organizations are also represented on this call. As a continent, the time is now. We need to act now, but most importantly, we need to look beyond a one sector driven approach, but to fully embrace a One Health approach by ensuring that we involve relevant stakeholders from human, animal, plant, and environmental agencies. We must continue to advocate and implement policies and laws that can enable long-term prevention and control of AMR on our continent. We must not miss the most important people, because these are the people that will connect experts such as you and I to the layman who doesn't understand what antimicrobial resistance is. We need to engage civil society organizations and youth groups to tell our story, to advocate for us at the ground level. As Africans, we need to start exploring private partnerships and heavily invest in research. As you can see, one of the things that we are learning from COVID-19 is how to bring investment onto the continent such that we start developing our own vaccines, our own medicines as well. Finally, we need to continue to work together. One of the things member states will always tell us is the scarce human resources. It's important as partners, development partners, technical partners, as well as other groups interested in supporting us as a continent. We need to continue to explore ways to build the human resource capacity on our continent such that we are able to address AMR, issues around AMR surveillance and control. CwPAMS has brought the spotlight to a unique group of healthcare workers, the pharmacists. I'm hoping that with this event and over the next couple of days, our discussions will lead us to explore more joint work plans, coordination, leading high-level advocacy, and building capacity for antimicrobial stewardship, cognizant of our unique needs on the continent and making sure that it's a continent-driven approach. On behalf of Africa CDC, we are excited to be part of this event, and we remain committed to exploring collaborations with several partners and of course our member states to improve the health outcomes on our continent. I thank you very much for your attention. Over to you, Ben.
Dr. Alimi, thank you so much for that very informative and analytical presentation. Also for the authority with which you speak about that One Health approach, which is so vital. May I also say that we welcome the leadership CDC, Africa CDC is bringing in this space. That leadership is so important. Your reference to a continent-driven response is crucial, including, by the way, the right of Africa to develop its own vaccines, which seems to me one of the most important things that we need to achieve in the immediate term. But just to say, I suppose what we're reflecting on today is a shared story of humankind, isn't it, without being too pompous. Yes, to a continent-driven response, but yes, also to a global response. Your fate is our fate. We're in this together, and that's what we've learned. Of course, from the COVID pandemic, and it's the conclusion we should be drawing about the silent, or the slow and silent pandemic, as Dame Sally Davies referred to it. Thank you so much, Dr. Alimi, for that fantastic contribution. I'm now going to turn and complete the picture, our final keynote of the morning, from Tom Pilcher, who's Deputy Head of the Fleming Fund. I should say, by the way, that all the biogs of people have been shared. There's a link that's been put in the chat box. So if you want to read more about the speakers, please do follow that link. But it's a delight to welcome Tom Pilcher from the Fleming Fund. The Fleming Fund is an enormous program of work, 265 million, of which we are a very small part. I hope we're a sort of much valued and precious part of it, but we're proud to be, if you like, part of a bigger picture, a bigger story, a bigger effort being driven by the UK. And I have to say that our experience of being partners with the Department of Health and Social Care in England has been fantastic. the last 16 months, as we know, have been extraordinary and unprecedented and required us to be incredibly flexible. And the conversations we've been able to have with you at DHSC have been an absolute joy. So thank you for joining us, and over to you.
Ben, thank you very much. And thank you for the opportunity to follow such a wonderful and inspirational speech from Dr. Alimi. Wasn't that just fantastic? So yes, I'm delighted, absolutely delighted to be here today to help celebrate the success of CwPAMS and its achievements of its partners. I should start off by saying, as funders, just how pleased we are with the programme, and are committed to ensuring that learning from this project is shared as broadly as possible to help catalyse further action on AMR. And as you mentioned, Ben, CwPAMS is a small but absolutely critical part of the Fleming Fund. We consider its mission absolutely core to what we're trying to do, putting data into practice to help improve stewardship for the benefit of all and saving lives, most importantly. So if we could go on to the next slide, please. So today I'll just very quickly provide an update on the Fleming Fund and where CwPAMS fits. I'll provide a snapshot of the progress that's been made in recent years. I'll provide a bit of an oversight of the kind of opportunities and challenges that have arisen, and also dwell on some of the learning, and then before turn on to some reflections on what next for the Fleming Fund over 2021. Go on to the next slide, please. So just a reminder of the Fleming Funds, what we're all about. Our primary goal is to build AMR surveillance to improve the quality and quantity of AMR data. This is highlighted within the Global Action Plan, one of the 7 key areas that we need to do. There's a lot of data that we need in order to drive improvement, to drive action and investment at a global, regional and national level. And right now we just don't have sufficient data to be able to do that. The other thing to remember about the Fleming Fund is that we are a One Health programme. We invest in animal health, environmental health and human health, and we try to do that equitably. We engage with a whole range of different stakeholders, including the OIE and FAO, as well as many others, to try to ensure that we tackle the problem holistically. So on to the next slide, please. So very quick overview. I'm trying to get through 10 slides in 10 minutes. You've got lots of exciting discussion later on, so I shan't dwell on this too long, but just to see, our focus and our aims are about building country partnerships with a range of governments and organisations. We want to equip countries with data to be able to make decisions for themselves, and we want to encourage clinicians and farmers to use antibiotics better. You can see that's exactly where CwPAMS fits. And encouraging governments to invest in tackling AMR over the longer term and helping to improve policies in relation to AMR also. Can we go on to the next slide? So here is where CwPAMS fits as part of the overall Fleming Fund investment structure. If you just click again, you'll see CwPAMS fit in. There we go into the third part, fantastic. So we have 27 country grants, 11 regional grants and 12 other major grants, including CwPAMS, which are broadly split into 3 separate parts. The first part, and the largest, is about strengthening national surveillance systems and AMR workforce capacity. That's kind of the core capability at country level, which involves investment in new laboratory equipment, refurbishing of labs and training, for example. It's also complemented by over 130 fellowships across the over 20 countries in which we work to really champion AMR and provide professional expertise in AMR from epidemiology and microbiology and a whole range of other specialisms which are really critical. The second part is about the enabling structure, making sure the right governance is in place at a regional, global and country level. So we have a range of grants with WHO, FAO and OIE to help improve guidance, provide protocols. And for example, right at the outset, we were able to fund partners to support the development of national action plans in over 65 countries. That was a really critical first stage to our mission, to make sure countries had a locally developed plan which could then inform investments, and particularly on AMR surveillance from the Fleming Fund's perspective. Now, the last part, and of course, perhaps the most important part, is around improving awareness of AMR and the use of data. That's where CwPAMS fits in. Data is not data unless it's being used to drive change in practice and policy, and helping to deploy data at a local level, just like CwPAMS does, to improve the treatment for people on the ground, to help save lives and strengthen the stewardship of antibiotics, is absolutely critical to our mission. So this is kind of core. You'll also see at the bottom as a little purple square which relates to our independent evaluation. Because we're a novel program, we are determined to share the learning from what we do as broadly as possible to help inform and catalyse other activities, and that's why we work in such a range of different countries. So if we go on to the next slide, please. Thank you. Here you'll see the country partnerships that have developed over the last 4 or 5 years. We have over 20 to date, and as I mentioned, we work to ensure that basically we're guided by local government's national action plans for AMR. We consult heavily with One Health ministries right at the outset and throughout these partnerships, and really focus investments on national systems, not parallel ones. This partnership approach, which CwPAMS knows all about, it takes time, but aims to build country ownership. And we see this as the real route to kind of impact and kind of longer term sustainability for our programme. If we go on to the next slide, you'll see that we can just reflect a little bit on the progress we've made over the last few years in strengthening laboratories and also improving the sharing of data at a global level. The first graph on the left-hand side shows the improvement.
Tom, you've gone on mute. I think if you could bring yourself off mute, thank you.
Thank you very much, Ben. That would have been embarrassing. So, yes, you'll see GLASS is covered in the first graph. We've seen a steady improvement in submission of data to GLASS, and we hope to continue with progress over the next year or so on that. This second chart shows the rate of improvement in human health laboratories. We work in animal health laboratories as well, but I thought you'd like to see today the improvement shown in the core capabilities as assessed by something called the LSHGM roadmap in those laboratories' ability to generate high quality AMR data, to analyze it and to share that. So you've seen overall, we've seen an improvement about 20% across all the laboratories and all the countries that we work in. The rate is unequal because we started in some countries before others, but we expect very much to be able to reach 100% in many of the countries we work in before the end of this current phase of the programme. So that is remarkable and something to be celebrated. Okay, on to the next slide, please. I think here I'd like to reflect a little bit on how CwPAMS contributes to the core principles of country ownership and sustainability. Now, these are absolutely critical principles for the Fleming Fund. We're very proud of CwPAMS achievements, and we know that its success is due to the health partnership approach. This model of working within local and national plans, peer-to-peer learning, capacity development, it's a highly successful and sustainable model. As I mentioned, this aligns with our principles of country ownership and sustainability, and I think it's important to draw some of these messages out. So, as I mentioned before, we very closely align to national action plans to make sure that what we're doing is supporting the overall plan of national governments and their work to strengthen health systems. We don't want to build parallel systems that aren't integrated and that don't contribute to the priorities of local health ministries, as they're best placed to understand the needs of their constituents. So for ongoing collaboration with national governments, we try to establish cross-sectoral country-led AMR governance structures, ensuring that the ultimate owners of our investments are national governments. And it's through building capacity of clinicians, pharmacists, and national stakeholder engagement and feeding into local national plans that CwPAMS increases country ownership. In terms of sustainability, this is critical for our mission. In terms of the investment of up to 265 million, we need to demonstrate that we've had longer term impact. So we consider very carefully countries' motivations, resources, priorities, and their existing AMR activities from the start, including looking at other partners that are there on the ground to make sure that we're aligning very, very carefully with existing structures. This is a real challenge. It takes a lot of time, but it's very much absolutely critical to invest that time to make sure that you work in line with what has already gone before you. Although we provide a large amount of resource, we are not the end of the story. We need to leverage and catalyze further activity. We need to encourage further investment. And we need to do that in a way for building strong partnerships across a whole range of different stakeholders. So investing time in building relations is really critical. And as we come on to later, it's one of the main messages from the project. So I think I'd just dwell very quickly on CwPAMS strategies that are used to ensure change is sustainable, including establishing medical and therapeutic committees, include AMS and IPC subcommittees, monitoring behaviour change through collecting data to promote AMR surveillance and evidence-based prescribing, empowering AMS champions to advocate for AMS in hospitals during and also after projects. So it's really apparent to us that the development of guidelines, protocols and processes really helps to build institutional change in conjunction with the formation of committees as well as the appointment of AMS champions. So we're really delighted with the approach to sustainability that CwPAMS has taken. I'll just move on to the next slide, please, if I can. So for 2021, there's a kind of new context for us. It's a transitional year. The first phase of the Fleming Fund is due to come to an end. So we'll be looking to think about how we can build sustainable change during this phase and the potential for a second one, and what priorities and new priorities we need to focus on to achieve, and what learning have we taken from the past few years as well. COVID-19 is still very much with us. We see new waves. We just had a meeting this morning where we're looking at kind of the epi curve in Africa and how that's likely to impact on our operations and grants on the ground, what we can do to mitigate against that, to ensure that our grants can continue the work insofar as is possible and we protect our staff, as well as also looking for opportunities, which is really critical to highlight the value of the Fleming Fund's work in this context, potentially flexing resource where appropriate as well, in particular key areas such as whole genome sequencing. And lastly, we're looking at global cooperation. I'm sure Dame Sally pointed out, we have the G7, which the UK chaired, and there was a strong AMR track, which really championed AMR at the highest level. They need data to inform those discussions to make sure global policy is informed, and we are trying to make sure that we get as much data at these levels, at the G7, at the G20, at the WHO, at the high level dialogue that was at UN, to help policymakers and to incentivize action. On to the next slide, please. So I just wanted to quickly cover some of the learning challenges and opportunities that we've had experienced over the last year. This has been informed by our evaluator. The first of which is realism. It's taken much longer to build country partnerships than we anticipated, which is always due to inevitable optimism bias. But we put the time in and we've got those on the ground now, which we can now work with closely to deliver change. COVID-19 has impacted on delivery, but it's also put global health security on the centre stage and many discussions, and we can work with that and draw on, as Dame Sally says, the silent pandemic, and say, look, we need to prepare for AMR now, invest now, if we want to make change and protect ourselves in the future. We need to invest in coordination and alignment. It takes time, is resource intensive, but this can help multiply the benefits for our partners, and we need to do it. We know that countries in Africa and Asia, we need to be aligned as donors before we come to countries and help to provide activities to help reduce the transaction costs for partners on the ground. And as I mentioned before, we need to continue to demonstrate the value of AMR surveillance and highlight its relevance to COVID-19. If we go on to the next slide, please. So what we need to deliver in 2021, we need to ensure the labs we've invested in are working, that they're providing data, that it's being shared, that it's high quality. That's the core to our mission, and we'll be focusing on it over this year. We'll also be making the case to invest through demonstrating the relevance and value of AMR surveillance. So I just want to point Seek Africa as our whole genome sequencing project, which actually works very closely in alignment with Africa CDC and Dr. Alimi's teams in trying to enhance whole genome sequencing capability to able to track AMR and how it developed. But also we've been able to flex into COVID-19, and sequencing has been done in a number of centres that we work with, including in Ghana and also South Africa, which has been really valuable. And that helps to show real value of data to public health, how it can help save lives at scale. I'd also like to highlight that later this year in July, we'll have new estimates of the global burden of AMR coming out in July. This will help to make it feel real. We'll be able to have, for the first time, some real high quality data and a large amount of data informing our understanding of basically informing our understanding of the mortality and the impact of AMR globally and at a regional level. So do watch out for that. I think just come on to the last slide, please. I did just want to conclude by thanking you for all of the fantastic work that's been done in a partnership. CwPAMS is a real exemplar for what can be achieved through collaboration and partnership, and it's something that we will be sharing the learning of across our partners and much more broadly as well. So I'll conclude by saying thank you very much to everybody attending today. Delighted to be here.
Thank you so much for that, and for the expert view on what makes partnership working effective across borders. But also congratulations on the UK government commitment. There's clear leadership in this field, and I think we acknowledge we've taken a bit of a battering in recent months for some of the decisions that have had to be made around UK aid cuts, but clearly this is an area where the UK is providing global leadership, and it's very exciting to hear you speak. I also think you've set us up brilliantly for the breakouts. The learning challenges and opportunities slide, I think, was particularly good. And if I may, just to emphasize your points on country ownership and the importance of that, of aligning with national efforts, not building parallel systems, as you said. So as we go into the breakouts, it occurs to me that that's one of the ways, that's one of the tests that we should discuss. Did we achieve that? The evaluators say we did, we think we have, but nevertheless, we want to be able to hear your view on that and discuss it in the breakouts. Thank you so much, Tom. I think there would be a standing ovation. I absolutely believe that our first three speakers have been everything we hoped for, and they've given us a wonderful full picture to set us up for the day. And I'm so pleased that we've passed over 100 delegates, including from some of the countries where we want to partner with going forward. Nigeria, Malawi, Kenya, and Sierra Leone are also represented here. So thank you very much to you for coming to this meeting.